Everybody. Thank you for joining us this afternoon on our asthma webinar. So my name's Jatinder. I'm one of the pediatricians over at Down Valley Hospital. I'm also one of the STPN clinical leads for pediatric critical care. And I'll be kind of talking from a DGH perspective. And then after me will be Nick, who's one of our other clinical leads for pediatric critical care. And he'll be talking about asthma, status asthmaticus from a PICU perspective and when it starts to get really complicated. So please do kind of feel free to kind of jump in and ask any questions. Happy to make it as interactive as you like. Okay. All right. So hopefully I can. Okay. So, well, what comes first? Before I think we talk about acute asthma in the DGH setting, something that actually I think as colleagues, we're all very good at looking after children with asthma, and I think it's sometimes the really complicated ones that's where we kind of shout for help, and that need further escalation of treatment and need to go to an intensive care unit. That's where it really kind of gets quite complicated. But I think before we talk about acute asthma and DGH setting, it's really important that we talk about, from a DGH perspective, chronic asthma and how we kind of prevent exacerbations. And I hope to kind of just set the scene a little bit about that. So asthma mortality, well, UK sadly has one of the highest prevalence of emergency admissions and death rates for childhood asthma. This graph you can see here is taken from a global burden of disease study, last accessed. This was done in 2019, but the study was 2016. And this was a picture, as you can see, I took from another presentation on asthma, but you can see very clearly where UK sits, and you've got so many other countries that are have got lower mortality rates than we do, and there's a number of kind of reasons for that. I'll think just to make it very real, the reality of asthma is asthma kills, and this is a child who had passed away a few years ago, but the coroner's regulation 28 report was published just recently, December 28, with an intention to prevent future deaths in asthma. But the sad truth is that there's been a number of reports to prevent future deaths in asthma, but we're still way away from achieving that, and it's not really just a single approach. We need a multi-pronged approach on how to reduce asthma deaths. But this was sadly William Gray, who had a life-threatening asthma attack in October 2020, went to his local hospital, to their A&E, and he initially was not commenced on inhaled corticosteroids and discharged from A&E, or as far as I'm aware, and the report showed that from primary care services. GP subsequently treated him with 3 courses of oral steroids over the next kind of 7 months of recurrent exacerbations. But on the 4 days after the 4th course of oral steroids and no inhaled corticosteroids, he passed away in May 2021, so 7 months after his first life-threatening asthma attack. And that regulation report came out to prevent future deaths. And I apologize in advance if this is a case that occurred in your local hospital. But the truth of it is we've got very similar cases in all our hospitals across the country. And it is just another sad example of asthma and how life-threatening it is. So the risk factors of asthma death, sadly, they've been known for quite a long period of time. We've known it for decades. Excessive use of short-acting beta agonists, i.e. salbutamol, is life-threatening. That came out of the NRAD review and 2019 global initiatives on asthma. We know that insufficient inhaled corticosteroid usage is associated with asthma attacks and deaths. The NRAD, they recommended that anyone having 2 asthma attacks in a year should be referred to asthma specialists, and a confidential inquiry demonstrated that more than 2/3 of those who died from asthma between February 2012 and January 2013 had major preventable features, and that was the NRAD study that was done in 2014, so 10 years ago. The major preventable risk factors that they do keep recurring. Asthma attacks are all too often treated as if they were single acute episodes with no real kind of long-term consequences and no real joined up care to recognize the patient in the middle of it presenting with recurrent presentations, both exacerbations and ongoing symptoms. And it was felt that there was a total failure to not this case, but in our management of asthma, to recognize risks posed by repeat acute episodes, and often these children seen it in A&E. We refer back to GP, but we don't think actually this life-threatening exacerbation or this was severe enough exacerbation. They came in a few months ago. We don't look at it from that perspective and think actually maybe I will start and then on an inhaled corticosteroid and then ask GP to review and follow that up. And that's perhaps something we should be getting better at doing, whether we're seeing them in our pediatric A&Es, whether we're seeing them in our pediatric assessment units or short stay units, or onto our children's wards or young persons wards. Acute asthma is often treated as if it's a short-lived inconvenience, i.e., it's not a red flag when a child presents with asthma that their chronic disease is out of control. So, as I said, we just treat the symptoms, what we see, treat the wheeze, the 3 days or 4 days or 5 days of steroids or a stat dose of dexamethasone, and then we send them home thereafter because they've ticked the box and weaned to 3 to 4 hours, not required oxygen, and look a bit better in themselves. But we don't see that actually that presentation is a red flag that their control, their asthma control is poor. They're having exacerbations, and really that's what we need to tackle. We know that at least nearly 10% of the UK population, or 1 in 10 children in a class, you could say, this is the whole UK population, but also in children as well, have asthma. Annually, we have 6.3 million primary care consultations and 93,000 hospital inpatient episodes across adult and children, and 1,800 intensive care unit episodes. So it's clearly a significant condition and lots needs to be done about it. So the NRAD was done in 2014, and we're now, as I said, 10 years on from that. And the feeling is that things have improved, but there are significant changes that have not occurred. There was expose a very simple fact after 10 years that, again, most asthma deaths are avoidable. It highlighted structural systemic problems of delayed assessment, diagnosis, and treatment of asthma leads to unsafe levels of healthcare provision and inadequate support for people with asthma and their carers to appropriately manage their condition. And there are a number of kind of evidence-based recommendations that were made from the 2024 review to improve care. 2014 review to improve care, and in the 10 years since that review initially was published, we know that asthma deaths have increased by almost 25%, and 4 people still die from an asthma attack every day, yet 2/3 of asthma deaths are avoidable with better basic care. And then the 2024 survey of over 12,000 people found that the rates of basic asthma care have stagnated, with only a third of people, less than a third of people with asthma receiving all the elements of good basic care. And I think that's one thing that I just really want to kind of emphasize before we start thinking about how do you treat that child that comes in with severe asthma. It's not just that presentation, it's what else is going on for them. This is a red flag, as you saw in the previous slide, for a chronic disease that we need to get better grip of. So great progress has been made over the years, however. So the NHS Long-Term Plan 2019 has a focus as respiratory as one of the clinical priority areas. Biologics and Pheno were chosen as rapid uptake products in the Accelerated Access Collaborative. And so following that quick uptake, there were widespread Pheno usage. And I believe initially when the 2014 NRAD was done, there was only 1 biologic in use, and now we've got 6+ biologics in use. The NHS England created a national bundle for children and young people with asthma, which was clinician-focused resources to deliver high-quality care within the ICSs. Standardized guidance. This is something that's on its way. This is being developed kind of from now onwards, and that's a combined consultation of NICE, BTS, and SIGN guidelines, because the reality is there's lots of varying guidelines, and it leads to confusion of what's the best way to go. There's no unified message, so hopefully when that standardized guidance does get published, that will help clarify things. There's also a push towards, especially the older children, the young people, to use MART or SMART regimes, which are regimes where you've got your combined reliever and preventer inhaler within one to reduce your symptoms and exacerbations. And then there's also just recently a bill that came out, which is the Tobacco and Vapes Bill, which essentially says that it will make it illegal to sell tobacco vaping products to anyone that's born after January 2009. So that means anyone from over the age of 15 will not be able to buy tobacco products going forward to create a smoke-free generation. And then the national audit in asthma 2023, which took over previous audits, is an ongoing national audit to improve care and outcomes in asthma. So, what are the essentials in asthma? So, basic asthma care, that's something that's a priority for all children coming in at acute settings. And that is to ensure they've got good inhaler technique, they've got personalized asthma action plan, and at least annual asthma reviews. And this is, again, something that needs to be done kind of collaboratively in primary and secondary care to prevent these children then coming into secondary care and deteriorating further to tertiary care and sadly death if they have severe deterioration. Um, it recognized that you need designated leads and teams, a strong workforce around asthma management. And I think that's more the case for children and pediatric asthma, because actually there is lots of work done in adult asthma, but it's not always translated into best practice for children. And we'll see children being given devices that they are not actually able to use, but would be more possible and feasible to do in adults. And so we need to kind of have designated leads and teams at all levels there. Those that have very severe asthma, they need better access to biologics going forward. And so I think from our perspective, secondary care perspective, it's really important that these young people, where they've got severe asthma, are referred early to tertiary service, tertiary respiratory, to really see actually would they benefit from a biologic sooner than we already think of. Follow-up care. So 10% of cases that were studied by NRAD had died within 28 days of being treated in hospital, which is actually a very high number when you think about it. It's really essential that there's early follow-up to ensure that adequate recovery has occurred. And there was a recent study by University of Birmingham that identified that only 18% received follow-up with their GPs within 48 hours of their discharge, following discharge, and only 60% received a follow-up appointment within 28 days, i.e. 40% did not. Next is to do with our patient records and prescribing. So we know that overuse of your SABAs, your ventilating salbutamol, is associated with poor symptom control, and its evidence suggests that SABA overuse is associated with increased risk of exacerbations and death. If we had better data and sharing, we would be able to alert ourselves better to excessive SABA use. But I think we are getting into an age where electronic prescribing and electronic records, where you can see GP records, is more feasible. And I would urge colleagues to, when you have got these facilities available and you've got a complicated a child present with asthma, and thinking about them in your outpatient settings or in your ward settings, to really think that, can you access their GP records or highlight to the GP to review how much they are receiving in terms of their SABAs, and are they using more than they should be. And that's really important part of asthma reviews, is not only are they collecting too many SABAs, but if they are on a preventer, are they collecting less than they should be, indicating kind of poor compliance and adherence to their treatment. We know that their smoking has an ongoing impact, including passive exposure, and this is more prevalent in a deprived community. So again, all children coming to our outpatient setting and young people should be kind of educated, and families educated on smoking and vaping, which is on the rise at the moment for our youngsters as well, adolescents presenting. And then care in non-medical settings. So asthma deaths in schools rose between 2012 and 2022. A study showed by more than 33%, which is quite significant. And so NHS England CYP transformation program developed resources for schools, but we need to have that widespread awareness of children not only in the hospital setting, but their school settings as well, and education of the teachers that are giving them their inhalers, and not necessarily escalating as appropriately as they should be. Again, from secondary care and even tertiary care, this isn't something we can immediately manage, but I think this is important to be aware of, and so that we can, as clinicians and teams looking after children with asthma, start thinking about how do we engage with our community to improve asthma control. So that's the chronic really part of when we talk about asthma, and the things to kind of really be aware and to remember. I'll very briefly talk about status asthmaticus. We have this, which we've all kind of seen variations of this before. This from BTS 2019, as I said, that when the new guidelines come out, which are the shared kind of guideline between the key guidelines, we'll be able to update again with that. But there is recommendation of children should be triaged kind of within the 15 minutes and assessed their level of severity. And that is based on mild, moderate, severe, or life-threatening. And there's various factors which will be able to guide you of where they fit in this. And this is an example. There's lots of kind of variations of this and different flow charts and algorithms and integrated care pathways that can be used in asthma as well. And I'm sure you'll all have similar in your local hospitals. So mild to moderate, severe, life-threatening saturations, their use of salbutamol before presentation, signs of respiratory distress, their Pew score. Now, of course, this Pew score will vary depending on your local Pew scores that you're using, and soon we should be able to, with encouragement, move to kind of national Pews and all speak the same language of when we say Pews and what that means. But this will be relevant in your own settings. Peak flow, I think we very rarely do peak flow in the acute care setting in A&E, but I think this is something that is a tool we can use, not only actually at the point of children coming in, but also at the point of discharge to make sure that that bronchoconstriction that is present has been improved significantly enough to get them home safely. Their ability to speak and their breathlessness to speak, their GCS, and then their vital kind of signs, their heart rates and respiratory rates. These are kind of key things in assessing their levels of severity. And it's based on that level of severity that you will then subsequently go on to your treatment. And again, this is an example taken from our hospital at Down Valley Hospital, but there's many, I'm sure you've all got standardized approaches to managing acute asthma. If somebody, whoever is not muted, if you could please mute, I'd be very grateful. Thank you. And so please kind of follow what you use. And if you don't have anything in your current settings, then it's worthwhile having some focus and on making a guideline that will kind of guide your teams to managing acute asthma. But the reality of this is a mild, moderate, severe to life-threatening. Most often in a non kind of severe or non-certainly non-life-threatening where there's no oxygen requirement, you can use inhalers. The key thing with the management of asthma is ensuring that you review these children, reassess them. Are they responding? Is their clinical condition improving or are they deteriorating? And that's that close watching, constant reassessment, which will be pivotal to that. Someone who's very unwell with low oxygen saturations or severe asthma, we're following our EPALS or APLS protocols of calling for help, giving oxygen, getting access, doing all these key interventions as part of your a thorough A2E assessment. But once you've kind of got through that and you're now assessing them, the majority of children can be especially that you think, actually, I might be able to get this one home, they're not too bad, are people who we can use inhalers with as well. And it again gives you the opportunity to really reinforce good inhaler technique. And there's many times where I've used that in A&E and gone through it with families, and even though they've been taking salbutamol at home and that's led to the deterioration not working, coming into A&E, we often see that their technique is quite poor and their compliance and medication. Again, it goes back to that education, which is really, really important to empower families, carers, and young people, children, to help manage their asthma better and recognize when their control is poor. And that goes back to the basic care I mentioned in asthma. So reassessment is key. Often we will say that if you are kind of 3-ish plus hours not requiring any inhalers, no oxygen requirement, and stable, that's somebody who can potentially go home. Again, checking inhaler technique. If you've got hospital at home teams, you can use them as well. And it's really key that you've got your follow-up within 48 hours with the GP. And I know that can be a challenge, but it's something that is recommended to see that these children are adequately recovering. Those that are presenting with exacerbation, recurrent exacerbation, they must be started on preventer treatment. And families really need to understand what it is about the preventer and why it makes a difference, and why it will take a while to work, and why you can't miss the just occasional dose, because that will kind of deteriorate their asthma control. Those that are severe, we start thinking about burst therapy, and there's variations of how you do this. And you see some centers that would do kind of atrovent, salbutamol, nebulizers, followed by two further salbutamols, or others that will do salbutamol, atrovent, and do that 3 times, 20 minutes apart. There's no set rule of how you do your burst therapy. I think the key thing is making sure that we're constantly reassessing, making sure that they are improving, and if they're not, then escalating the treatment. And the management of asthma is, essentially as BTS guidelines is. If you can use inhalers, use inhalers. It's very important that we give these children steroids, ideally within an hour of their presentation, so that that helps to kind of have that anti-inflammatory effect sooner rather than later. Some centers using dexamethasone, which is usually a one stat dose, can be repeated later if needed as well. And if subsequently not improving with that, then would need to go on to a prednisolone course. But there's variations in what you will practice, and but depending on your local kind of asthma respiratory leads. Of course, life-threatening is a child who we're very, very worried about, had the signs as in red that we saw previously. This is where we need very kind of senior review of these children. Making sure that we are monitoring them closely, that we are giving them their bronchodilators, and we're considering them for intravenous bronchodilators if there's ongoing deterioration, and aware that if they were to deteriorate further, that their care would require escalation further to that, potentially non-invasive support, and could lead down to intubation ventilation. And it's really important to have that trajectory in your mind very clear, so that you can assess these children from point of presentation to their constant reassessments, that are they deteriorating, and escalate again that early. Of course, we've got our retrieval service, Southern Retrieval Service. Children that are very unwell, that's a call that's made to a retrieval service. And if you're not too sure and think actually they're pretty bad, but they might turn the corner, that's someone that you can actually still call and get advice for, or give forewarning that we've got this asthmatic child who's very unwell. We are concerned, and ensuring that you've got your local teams involved early, so your consultants, your nursing charges, and your anaesthetic teams to review them, so that should they deteriorate, that you are ready to stabilize them quickly. The STRS guidelines that I kind of mentioned, it kind of summarizes that as per BTS guideline, maintaining oxygen saturations, inhalers, which can be repeated if severe or oxygen requirement, life-threatening requiring nebulizers, steroids, getting them in early, using hydrocortisone intravenously if oral not tolerated. And often I think we'll find that the very severe asthmatics will be a lot quicker to give them intravenous hydrocortisone. And I don't think that's a bad thing. We will need intravenous bronchodilators if they've got worsening clinical status, and this is our kind of second line treatment. Again, there are variations to this, and again, BTS guidelines also mention nebulized magnesium sulfate as well. And when we think about which bronchodilators intravenously we're going to use, again, you've got to go by your local guidelines. SGS guideline here, kind of first line is magnesium sulfate. I think it can be very effective. You can use a second dose if they have good response. They can have usually just a mild hypotension, usually not clinically that significant, and just need a blood pressure monitoring, but may require a small 10 mils per kilo fluid bolus with that as well. But it's usually, in my experience, quite well tolerated, including second doses. Then your intravenous bronchodilator beyond there, for requiring it, is you're going to give them a loading dose followed by an infusion if there's ongoing concerns. And I think you will choose which agent you use based again on your local protocol. And I think if you've got signs already of salbutamol toxicity, a child that's having already had lots of salbutamol at home, or had multiple nebulizers and reburst therapy done in A&E, or then again done on the wall, and you've got signs of salbutamol toxicity, tachycardia, lactic acidosis, your lactate going high, tachypnea as well, then that can be someone who you think actually we're not going to give them salbutamol infusion, but going to go for aminophylline instead. We know that as your lactic kind of acidosis worsens, that can worsen your respiratory function as well, as you try to blow off that acidosis. So actually it can contribute and make your assessment of that respiratory distress harder. So really being aware of toxicity of salbutamol in these young people, and knowing early when to call it that actually this is someone who is deteriorating and we need to escalate escalate their care rather than just really kind of, overloading them unnecessarily with bronchodilators. It's really important that we consider differential diagnoses of children presenting wheeze and breathlessness. X-rays can be very helpful to identify if you've got any other kind of significant complication like pneumothoraces, significant consolidation. But in clinical history and examination, you may have other features which lead diagnoses as well. So bronchiolitis, for example, under 2 years of age, preceding cough, cold, cries or history, diffuse crackles, wheeze and auscultation. Often it's the wheeze doesn't just come from bronchodilation. And we know from our learnings from bronchiolitis that often with nebulizers used here, we're usually treating ourselves rather than the patient. But there's a multi kind of factorial reason why they are wheezing, working hard, not just because of bronchoconstriction, but also that mucosal edema and mucus plugging, which leads to that wheeze and reduced air entry. So it's really kind of important not to overcook these children with your bronchodilators. I don't think it's unreasonable, as we saw in recent years, some older children presenting with bronchiolitis, older infants presenting with bronchiolitis with quite a predominant wheeze pattern that actually did have some response to bronchodilation. But it's important to be aware, is it just the bronchodilator, i.e. sabutamol atropine, that made that difference, or was it the wetness of the neb, i.e. just a saline neb? So my own practice, if I hear lots of wheeze and the child's significant distress, is I will think about, do I need oxygen? Do I need high flow? Do I need CPAP? Do I need to escalate? But if I'm at a stage that I think actually medically I could optimize things, I sometimes will give them a saline nebulizer as opposed to hypertonic saline nebulizer and just see, does that shift their secretions? Does that improve things for them? If it doesn't, I'll stop there. The worst thing to do is, give them a whole load of bronchodilator and then just put it on the drug chart and just keep regularly giving it when no one's actually assessing and reassessing these children. I think we know what the evidence is, but we still have to take that pragmatic approach to the child that's in front of you. And that's where the constant reassessment is really important. Episodic viral wheezes. So these are children where there is limited evidence for oral steroids, and it can be difficult to unpick that episodic viral wheeze from your child that's really presenting with asthma. Again, seek senior support, but there'll be other things in the picture that you might find, atopy, symptoms on at rest, coughing at night, and in between. So interval symptoms can highlight to you that this might be something more that's going on with this child, other than just the occasional viral wheeze that doesn't necessarily need steroids. Atypical pneumonias, so and both viral bacterial pneumonias with significant consolidation on X-rays. Important to be aware of anaphylaxis of the children presenting with wheeze. And also aware of the fact that nebulized adrenaline or intramuscular adrenaline can also make a difference in bronchodilation, improve things as well. And it doesn't always indicate there's anaphylaxis, but being aware of that being a treatment as well, and not kind of thinking that it must have been anaphylaxis that caused it and not actually their asthma because they responded to the adrenaline. Adrenaline has that bronchodilator effect as well. Cardiac failure, so children in failure can wheeze as well as another differential. Again, your chest X-ray and your clinical examination will help you to do understand what your differentials are here. And then foreign bodies. So previously well child who's short history, witnessed choking episodes, asymmetrical air trapping on chest X-ray, although X-rays can be normal. Again, having that high index of suspicion that could this be a foreign body inhalation that is causing their symptoms. So hopefully your management of the child with asthma was effective, and we've thought about we're thinking about, their discharge home. And these are some of the kind of key things taken from our local guidelines, but there's a key kind of key practice that should be applied wherever we're seeing these children. So in your hospitals as well. So we should give them written management plans given to them and discussed and explained how to escalate the salbutamol in acute exacerbation, ensuring that they're only giving it when the child is symptomatic, and avoiding the weaning regimes of which has very kind of limited evidence around of giving 10 puffs every 4 hours and 8 puffs every 4 hours and 6 puffs every 6 hours. and bring it down. I think evidence suggests that that does not give actually is more dangerous, does not give the parents and carers the opportunity to treat exacerbations, and can lead to overuse and missing deterioration, which can be life-threatening. So you avoiding these weaning regimes that we used to use so commonly. After discharge, if the child is still requiring salbutamol, they must be reviewed 48 hours after the discharge, and it's really important to get this GP appointment within 48 hours for that, to make sure they're recovering adequately. But I think it's probably important that to say to families that if you cannot get that appointment, or it doesn't occur and you're still worried about your child, come back to us. The last thing we want is this child deteriorating further and presenting in a much worse condition. And then you've got your escalation plans. This is just an example of again, ours and other centres that use very kind of similar to this, of how you escalate it further, but essentially using salbutamol plus, reviewing it, assessing it, get your GP reviews. If it still doesn't work and all your 10 puffs don't last the 4 hours that they should do, or there's significant work of breathing, calling 999 and getting assessed urgently. And these are some of the key messages to take home for these families. What are the key national audit standards? So it's important that we give steroids within the hour from arrival, check the inhaler techniques before discharge, giving them personalized asthma action plans before the discharge, refer for smoking, secondhand smoking, cessation, vaping, even in the young person or in carers, and ensuring that they've got appropriate follow-up, ideally within 4 weeks, if this is a child who is representing either severe exacerbation, or life-threatening exacerbation, that they do go home on inhaled corticosteroids and preventive therapy and know how to use it, and that they receive GP reviews within that 48 hours. And so that's the kind of a DGH or pediatrician's perspective of asthma. And